Hello, my name is Cielo Borrinaga. I'm a clinical nurse leader at the Dallas VA Medical Center. As a CNL, I am now in the driver's seat in making clinical decisions and leading my team to evidence-based practice and quality care. I feel like I'm more empowered than before and have a voice to advocate for our patients and be a catalyst for change. On September 2019, before the height of the COVID-19 pandemic, I led a study engaging nurses in providing oral care in the prevention of non-ventilator hospital-associated pneumonia on two of the busiest medical surgical units at the Dallas VA. This program was a collaborative effort among many disciplines. Some might think that a basic oral care may not have a huge impact on patient care, when in fact it surely does. Studies show that aspiration of oropharyngeal secretions is a significant pathological event preceding hospital-associated pneumonia. Silent aspiration is more profound in our elderly and neurologically impaired patient population. For this reason, providing oral care or hygiene twice a day prevents the pathologic event from happening. Pre-data shows that there were 3 non-ventilator associated pneumonia or non-VAP cases, which equate to $40,000 in hospital expenses for each incidence, and 6 days more in hospital stay. I did a retrospective chart reviews using ICD code 10 for pneumonia and compared it with the CDC criteria for a non-VAP. There were 1 case during the pilot study. However, in December 2019, after the 3-month pilot study, our data shows 0 incidents up to 1 year, even at the height of the COVID-19 pandemic. One of the 2 medical surgical units that I am overseeing was even converted to a COVID-19 unit for overflows. This project proved its significance, positive outcomes, and sustainability even during these challenging times. In fact, early studies show the likelihood of having a secondary bacterial pneumonia following the initial phase of the COVID-19 infection, or can even occur during its recovery phase. This pandemic posed unique challenges for everybody, but the circumstances did not dampen our spirit and hindered us from serving our veterans. I attribute the success of this project to the hard work and commitment of the 6C nursing staff and also with management support. With this project alone, it saved my 2 units at least $160,000 of hospital expenses and 24 days less in hospital stays. Eventually, this project became hospital-wide. From this project, I can conclude that there's more productivity if there is sustainability. As a CNL, we tend to think outside the box, and we have a natural flair for innovation. Last year, I had the opportunity to participate in the COVID-19 Maker Challenge. It is a series of 5 challenges event that brought innovators from across the country together to develop solutions to the most pressing problems brought in by the pandemic. I participated in 2 events and won both. My team consists of highly skilled professionals from the Dallas VA Medical Center, Cleveland Clinic, and software and hardware engineers and graphic artists. My team created a portable ventilator with all the features of a full-scale ventilator at the fraction of the cost. My team's goal is to market and mass produce this to help resolve the ventilator shortage during this pandemic or any kind of disaster around the globe. From my own experience, clinical nurse leaders can be clinicians, risk managers, or even innovators, and the possibilities are endless. Now that's what I call the power of the CNL. Thank you.